Welcome to the deep dive. If you're a practicing clinician, an internal medicine resident, or honestly just someone fascinated by the sheer complexity of the human body, you are in the perfect place today.
Oh, absolutely.
Because today we are taking a magnifying glass to the ultimate clinical chameleon. We're talking about sarcoidosis.
The master of disguise itself.
Yeah, exactly. This is a disease that can mimic almost anything, silently wrecking multiple organ systems while just completely hiding in plain sight. It's notoriously tricky to pin down, and, managing it often feels like you're just navigating a minefield of clinical gray areas.
It really does.
Mhm.
And because its manifestations are just so incredibly varied, I mean, we're talking everything from completely asymptomatic incidental findings on a chest x-ray to sudden life-threatening organ failure.
Right.
Clinicians constantly find themselves caught in this tug of war. You're terrified of under-investigating, but you're equally worried about over-testing and harming the patient in the process.
Which is exactly why the source material we're looking at today is so vital for anyone actually seeing patients on the wards or in clinic. Today, we're diving deep into the 2020 official American Thoracic Society Clinical Practice Guideline on the diagnosis and detection of sarcoidosis.
It's a massive document.
It is huge, so let me state our mission for you right up front. We are going to cut through this massive, incredibly dense guideline and extract the most practical, bedside-focused clinical pearls. Our goal is to arm you with an actionable framework for your day-to-day patient care.
We're skipping the heavy theoretical pathophysiology.
Exactly. We're getting straight to the critical decision-making points you actually need. Okay, let's unpack this. How do we even begin to securely diagnose something that is defined by its ability to look like 100 other things?
It's the perfect starting point, really, because the ATS guideline establishes right away that the diagnosis of sarcoidosis is never 100% secure.
Which is a wild thing for a guideline to just admit on page 1.
It is, but let that sink in. There is no single magic blood test. There's no pathognomonic imaging finding that gives you absolute certainty. Instead, you're building a case based on a very delicate triad.
Right, the 3 pillars.
Exactly. First, you need a compatible clinical presentation. Second, you generally need to find non-necrotizing granulomatous inflammation in 1 or more tissue samples. And third, and this is arguably the most difficult part of your job, you have to aggressively exclude alternative causes of granulomatous disease.
You only get to confidently call it sarcoidosis when all 3 of those pillars are standing.
That's the baseline rule.
It's basically a diagnosis of exclusion combined with a very specific clinical and pathological fingerprint. So let's move straight into what I think is the most eye-opening part of this entire guideline, which brings us to our first major segment. We're talking high-yield clinical pearls.
My favorite part.
Right. When I was reading through the screening recommendations, I was genuinely shocked by the strength of the recommendations, or rather, the complete lack thereof. Out of this entire comprehensive, multi-page society guideline, there is exactly one strong recommendation.
Just one. Everything else is conditional.
And what blew my mind is that this single strong recommendation is something that costs pennies.
Baseline serum calcium testing.
Yes.
It is strongly recommended for all asymptomatic patients with sarcoidosis.
Just a basic, cheap serum calcium test. You'd think it would be a fancy PET scan or some novel biomarker.
Well, it comes down to a really elegant risk-benefit analysis regarding preventable harm. Hypercalcemia only shows up in about 6% of sarcoidosis patients.
So it's not like you're going to see it every single day in clinic.
No, you won't. However, the stakes for missing it are astronomical. The guideline points out that if this hypercalcemia is left untreated, nearly half of those patients will develop irreversible renal failure.
Half of them. That is a catastrophic outcome for something you could have caught with a basic metabolic panel.
It's exactly. When the committee weighed the virtually zero cost and zero risk of checking a serum calcium level against the life-altering outcome of missing it, they felt it mandated a strong recommendation. You check the calcium, you find it early, you treat it with immunosuppression, and the hypercalcemia resolves in over 90% of cases.
You've completely saved the patient's kidneys just by being thorough. That is exactly the kind of high-value bedside pearl you want to keep in your back pocket on rounds.
So we've protected their kidneys from the calcium spike.
Right. But beyond that one strong recommendation, there's a whole checklist of conditional baseline screenings suggested for patients who don't have obvious extrapulmonary symptoms. I want to run through these because they form a fantastic practical baseline framework.
Let's do it.
First up is ocular screening. The guideline suggests a baseline eye exam for all patients, even if their vision seems perfectly fine and their eyes aren't red.
You really have to push for that eye exam. Ocular abnormalities like anterior uveitis happen in about 26% of sarcoidosis patients.
Over a quarter of them.
Yeah, and uveitis can be incredibly insidious. A patient might just think their eyes are tired or dry, completely unaware there's a problem, until significant permanent damage has occurred.
Which can ultimately lead to blindness.
Exactly. Routine screening catches this early, when a simple course of topical or systemic steroids can stabilize or even improve their vision.
So we've protected their vision. What about the organs that don't give you early warning signs? Moving down the baseline checklist, we hit renal and hepatic screening. The ATS suggests getting a baseline serum creatinine and an alkaline phosphatase. But notice what's missing there.
The transaminases.
Right. The guideline makes absolutely no recommendation for or against baseline serum transaminase testing. They single out alkaline phosphatase over the AST or ALT.
And that relates directly to the pattern of liver injury we typically see with hepatic sarcoidosis. When granulomas infiltrate the liver, they physically compress the biliary tree.
Which causes a cholestatic pattern rather than a hepatocellular one.
Spot on. So you're much more likely to see an isolated, elevated alkaline phosphatase as your earliest red flag of liver involvement. Transaminases might bump up eventually, but the evidence just didn't support mandating them as a primary screening tool.
Plus, knowing about asymptomatic liver or kidney involvement early on drastically alters your choice of therapies down the line. You do not want to start a potentially hepatotoxic or nephrotoxic drug for their lung symptoms if you don't already know their baseline liver and kidney function.
It changes the entire management plan.
Exactly. Next up on the checklist is hematologic screening. The ATS suggests a baseline CBC, which feels pretty standard, but the data shows anemia is found in 22% of these patients.
That's a huge number.
It really is. If you've got a patient complaining of severe fatigue and shortness of breath, it's so easy to anchor on their pulmonary sarcoidosis and say, well, your lungs are inflamed, of course you're tired.
Anchoring bias is a huge trap there.
Right. But if you haven't checked a CBC, you might be missing a highly treatable anemia that's actually driving the bulk of their symptoms.
The final piece of the baseline asymptomatic screening checklist is cardiac. The guideline suggests a baseline ECG for all patients. Cardiac sarcoidosis is notoriously underrecognized and can present tragically as sudden cardiac death in an otherwise healthy-seeming person.
It's terrifying.
It is. An ECG is cheap, it's non-invasive, and it can pick up conduction abnormalities like a new heart block or ventricular ectopi. Sometimes, that weird ECG is your only clue that the granulomas have quietly infiltrated the myocardium.
But let's be very clear about what the guideline says not to do here, because preventing overtesting is just as important as knowing what to order. You shouldn't be ordering a baseline transthoracic echocardiogram, a TTE, or a 24-hour Holter monitor for these asymptomatic patients.
The yield is just too low.
Exactly. The sensitivity of an echo or a Holter for detecting early silent cardiac sarcoidosis just isn't high enough to justify the financial burden and the downstream cascade of false positives. You only reach for the echo or the Holter if the patient actually has cardiac symptoms.
Like palpitations or unexplained syncope.
Right, or if that baseline ECG comes back abnormal.
It's all about stepwise resource allocation. You don't send everyone for the $1 million workup on day one.
Which is a phenomenal transition into our next segment, the practical decision framework. We've talked about screening the asymptomatic organs, but how do we actually establish the diagnosis when the patient first walks through the clinic doors?
Step one of this framework is all about assessing clinical syndromes.
Right, because there are certain presentations that are so highly specific for sarcoidosis that the ATS guideline basically says you can stop your invasive workup right there. You are off the hook for a biopsy.
We're talking about classic textbook presentations here. Take Lufgren syndrome, for example. If a patient comes in with the classic triad of bilateral hilary adenopathy on an X-ray, erythema nodosum on their shins, and periarticular arthritis.
The pretest probability is well over 95%.
It's exactly. Or consider lupus pernio, those classic violaceous skin lesions on the nose and cheeks. Or Herford syndrome, which is uveitis, parotid gland enlargement, and facial nerve palsy. If you see one of these, the guideline explicitly suggests you do not need to sample lymph nodes or lung tissue.
You can just diagnose them clinically and rely on close follow-up. I mean, imagine explaining that to a patient. You have a scary-sounding disease, but your presentation is so classic that I don't need to stick a needle in your lungs.
It completely changes the clinical visit.
It really does. It saves the patient from a biopsy, potential complications, and a ton of anxiety. But what happens when the presentation isn't a classic named syndrome?
This is where it gets tricky.
Right. Let's say for step 2, you have a Friday afternoon consult. A patient got a chest x-ray for clearance before a routine knee surgery, and it shows isolated, completely asymptomatic bilateral hilar lymphadenopathy.
What's fascinating here is that the guideline actually makes no recommendation for or against a biopsy in this specific scenario.
None at all.
It is a genuine clinical gray zone. Let's look at the tension here. On one hand, asymptomatic bilateral hilar adenopathy in a young, healthy person is almost always sarcoidosis. And it's usually a benign, self-limiting phenotype that resolves on its own without treatment.
But on the other hand, telling a patient you have enlarged lymph nodes in your chest is terrifying. Both the patient and the clinician are naturally going to worry about lymphoma or tuberculosis.
So it forces a really robust shared decision-making moment. You could biopsy to be absolutely sure and relieve that lingering anxiety, or you could opt for close clinical follow-up with serial imaging to see if the nodes shrink on their own.
You have to sit down and discuss the patient's risk factors, their tolerance for uncertainty, and even the regional prevalence of diseases like TB. But let's say you and the patient decide that tissue sampling is necessary for those mediastinal or hilar nodes. This brings us to step 3, choosing the right biopsy modality.
Historically, the absolute gold standard was a surgical mediastinoscopy. You went straight to the OR. But the landscape has definitively shifted. When tissue sampling is deemed necessary today, the guideline strongly suggests endobronchial ultrasound-guided sampling.
Commonly known as EBS.
Yes, EBS is suggested as your initial test over mediastinoscopy.
Here's where it gets really interesting, though. If you look at the raw numbers in the data they reviewed, Medias actually has a higher diagnostic yield.
It does.
It sits at about 98% compared to EBUS, which has a diagnostic yield of around 87%. So you really have to ask, why on earth is a major society guideline suggesting the test with the lower yield?
Because you have to look at the holistic impact on the patient, not just the raw diagnostic percentage. Yes, EBUS has an 11% lower yield. That means about 13% of patients might need a second procedure if the EBUS comes back non-diagnostic.
Right.
However, EBUS is far, far less invasive. It's done through a flexible bronchoscope in an endoscopy suite, usually just under conscious sedation.
You're comparing that to a mediastinoscopy, which is a literal surgical procedure.
Done in an operating room. It requires an incision in the neck, general anesthesia, and significantly higher costs. Plus, the complication rate for EBUS is incredibly low, less than 0.1% in the reviewed studies.
Sparing the vast majority of your patients from a surgical incision, and the risks of general anesthesia far outweighs the risk that a small minority might need a repeat biopsy down the road.
It's a phenomenal example of modern patient-centered medicine.
It's not just about chasing the test with the highest number. It's about choosing the safest path to the answer.
Absolutely.
Now, let's pivot to some of the diagnostic traps waiting out there for smart doctors. This is our segment on common pitfalls to avoid. Pitfall number 1 is a huge one. Misunderstanding vitamin D testing.
This one is so critical.
If you're sitting in clinic assessing a sarcoidosis patient for vitamin D deficiency, maybe they're fatigued or their bone density is a little low, you absolutely cannot just order a standard 25-OH vitamin D level like you would for anyone else.
It's an incredibly dangerous trap to fall into. To understand why, you have to look at what's actually happening inside a sarcoid granuloma. Think of the macrophages inside these granulomas as a rogue vitamin D factory.
A rogue factory, I like that.
They autonomously produce an enzyme called 1-alpha hydroxylase. This is the exact enzyme that converts the inactive storage form of vitamin D, the 25-OH form, into the active, potent 1025-OH form.
And in a normal person, this conversion happens strictly in the kidneys and is tightly regulated by the body's calcium needs.
But in a sarcoidosis patient, these rogue macrophages are just converting vitamin D unchecked all day long.
So if you just measure the 25-OH level, it might look artificially low because it's all being rapidly converted into the active form by the granulomas.
Exactly.
If you mistakenly look at that lab value, think, oh, they're deficient, and prescribe a high-dose vitamin D supplement, you are essentially throwing gasoline on a fire.
The granulomas will happily take all that extra supplement, convert it into the active 1025-OH form, drive up intestinal calcium absorption to dangerous levels, and potentially induce severe hypercalcemia and acute renal failure.
That is exactly why the guideline clearly suggests measuring both 25-OH and 1025-OH vitamin D levels before you even think about starting replacement therapy.
It's such a counterintuitive physiological quirk, but it's crucial to remember. Let's move to pitfall number 2, which relates to cardiac imaging. Let's say you did your baseline screening properly and your asymptomatic patient had an abnormal ECG.
Maybe a new bundle branch block.
Right. You immediately suspect cardiac sarcoidosis. The reflex for many clinicians is to order a transthoracic echocardiogram or jump straight to a dedicated cardiac TET scan. But the guideline points out this is the wrong initial step.
If cardiac involvement is suspected, the data is very clear. You want a cardiac MRI or CMR as your initial advanced imaging test. And the reason you want CMR over a PET scan or a standard echo is the sheer depth of prognostic information you get.
An echo simply lacks the sensitivity to detect early granulomatous infiltration in the myocardium. It mostly just tells you if mechanical function is already compromised. By the time the echo looks bad, the damage is heavily advanced.
And when you compare CMR to PT, CMR provides superior diagnostic value because it detects late gadolinium enhancement.
Yes, that enhancement directly correlates with myocardial fibrosis and scarring. The presence and the extent of that scarring is a massive prognostic indicator for adverse cardiac events, like sudden cardiac death or dangerous ventricular arrhythmias.
You're getting an anatomical map of the danger zones. You should really only use a dedicated cardiac PET scan if a CMR is completely unavailable at your facility, or if it's contraindicated for the patient.
Like if they have advanced kidney disease and can't get gadolinium, or if they have an incompatible pacemaker.
CMR is the clear, undisputed winner there. Now, pitfall number 3 is another cardiology-related trap, stopping at the echocardiogram when you suspect pulmonary hypertension. We know that sarcoidosis-associated pulmonary hypertension carries a truly grim prognosis.
It really does.
The guideline says if your patient has persistent dyspnea that seems way out of proportion to their basic lung function tests, TTE is the right initial screen. But here is the massive pitfall. You cannot officially diagnose pulmonary hypertension based on that echo alone.
You absolutely can't. The systematic review highlighted by the ATS found that TTE actually has a 22% false positive rate for pulmonary hypertension in sarcoidosis patients.
That is nearly a quarter of patients getting a false alarm.
And it also can't reliably distinguish between pre-capillary pulmonary hypertension, which might be driven directly by the sarcoidosis compressing the vessels, and post-capillary pulmonary hypertension, which is just caused by left heart failure.
And the treatments for those two conditions are radically different. Giving pulmonary vasodilators to someone with post-capillary disease can actually induce pulmonary edema and severely harm them.
Because the false positive rate is so high, an abnormal echo must be definitively confirmed or excluded with a right heart catheterization. You cannot skip the cath lab if you're going to commit a patient to lifelong, incredibly expensive, and potentially dangerous pulmonary vasodilator therapy.
These pitfalls really highlight how nuanced the daily management of this disease is. It's not enough to just blindly follow standard internal medicine algorithms. You really have to understand the specific ways sarcoidosis breaks the normal physiological rules.
Which brings us to our next segment, what has changed and the differential burden. If we connect this to the bigger picture, the most profound takeaway for anyone diagnosing this disease is that finding a non-caseating granuloma on a biopsy does not equal sarcoidosis.
A granuloma is just a pathologic reaction pattern.
It's just the immune system's way of building a wall around something it can't clear. The differential diagnosis for that reaction is incredibly vast, and you have to systematically rule out the alternatives before you commit to the sarcoid label.
And what are the big ones we need to be hypervigilant about? Obviously, infections are at the top of the list. Tuberculosis is the classic mimicker anywhere in the world, but depending on your geography, you also have to aggressively look for fungal infections like histoplasmosis, coccidium, and cryptococcus.
Beyond infections, you have environmental exposures causing hypersensitivity pneumonitis or occupational hazards like beryllium exposure causing chronic beryllium disease.
And we also have to mention the massive, relatively new phenomenon of drug-induced sarcoid-like reactions, with the absolute explosion of targeted immunotherapeutics.
Especially immune checkpoint inhibitors used in oncology to fight melanoma and lung cancer.
Right, and anti-TNF therapies used in rheumatology. We are seeing patients develop widespread granulomatous disease that is entirely driven by their medication. It looks exactly like sarcoidosis on a PET scan, and it looks exactly like sarcoidosis under a microscope.
But the treatment is modifying or pausing the offending drug, not necessarily launching into primary sarcoidosis therapies. It's a modern diagnostic minefield.
It really is. And as we noted earlier, the major shift in practice solidified by this guideline is that transition away from the operating room and toward the endoscopy suite. EBRS has definitively arrived as the modern standard of care for initial lymph node sampling, which has entirely reshaped the patient experience during the diagnostic phase.
But as much as we love these new algorithms, the EBUS data in the screening checklist, there is a giant elephant in the room regarding the data itself. And this is where we have to talk about situations where clinical judgment overrides the algorithm.
Yes, because this raises an important question. How rigidly should clinicians actually follow these rules?
If you look really closely at the methodology of this ATS guideline, almost every single recommendation, even that strong one for baseline calcium testing we raved about earlier, is based on what the committee strictly graded as very low-quality evidence.
The sarcoid literature is largely full of retrospective cohorts, non-randomized observational studies, and highly selected patient populations from specialized centers.
There's a glaring lack of massive randomized controlled trials.
So what does this all mean? It means these algorithms are guides, not gospel. They do not and they cannot replace your clinical judgment at the bedside. You have to highly tailor your decisions to the individual patient sitting in front of you and the realities of your specific practice environment.
Precisely. Let's go back to that asymptomatic bilateral Hiller adenopathy scenario. If you're practicing in an area with a high regional prevalence of tuberculosis, your threshold to biopsy those nodes is going to be much, much lower than if you were in an area where TB is exceedingly rare.
And if you're at a community hospital that doesn't have a high-quality cardiac MRI program, you have to lean on PT scanning, regardless of what the ideal algorithm says.
And you always have to factor in patient preferences. Some patients will happily accept a slightly higher risk of a false negative with an EBUS to avoid a surgical incision in their neck. Others will tell you they won't sleep a wink until they have a definitive tissue diagnosis from a surgeon.
You have to treat the patient, not just the scan. It really is a delicate balancing act. Managing sarcoidosis means being hypervigilant about screening for silent, asymptomatic organ involvement, like rigorously checking those eyes and kidneys before symptoms ever start.
While simultaneously trying to pick the safest, least invasive path to a diagnosis, you're walking a tightrope between doing too much and doing too little.
It's the absolute essence of the art of medicine.
It is, and I want to leave you with a final thought to mull over. Since almost all of our current recommendations are based on this very low-quality evidence, and we still rely so heavily on physically retrieving tissue through scopes or surgery just to look for a granuloma under a microscope.
What happens when we finally crack the molecular code of this disease?
That is a fascinating horizon to think about. Imagine a near future where, instead of debating the nuances of EBUS versus mediastinoscopy yields or arguing over ambiguous false positive echocardiograms, we can diagnose sarcoidosis definitively using a simple blood draw.
That would be incredible.
Imagine identifying a specific genomic signature or a circulating biochemical profile that not only secures the diagnosis without a biopsy, but accurately predicts exactly which organs the disease will target and how aggressively it will behave over the next 10 years.
The physical biopsy might one day be as completely obsolete as the iron lung, replaced entirely by precision molecular phenotyping.
Exactly.
That would change everything. It would take the clinical chameleon and strip away its disguise completely. You'd know exactly what you're dealing with on day one. But until that day comes, we rely on the triad. Presentation, pathology, and aggressive exclusion, all guided by the practical pearls we unpacked today.
It's all about mastering the basics.
Thank you for joining us on this deep dive. We hope you take these insights, remember those baseline screening checklists, steer clear of those critical diagnostic pitfalls with vitamin D and echoes, and apply these frameworks directly at the bedside with your patients. Keep questioning the algorithms, keep learning, and we'll catch you on the next one.